All right, welcome back to the deep dive. We've got a really interesting topic today, super relevant for clinical practice, especially if you need a quick, high-yield refresher. You've shared your fantastic notes on goiter with us, and we're ready to jump right in. Think of this as us helping you unpack those notes, definition, causes, red flags, management, the works, our goal. Make it clear, make it stick.
Absolutely. Goiter is, well, it's a common sight,
Okay.
and your notes really hit home that it can signal anything from, simple iodine deficiency to something much more serious,
Yep.
understanding how to approach it, how to differentiate. That's key. And these notes, they give us a great roadmap. Let's get into the core stuff.
Okay, let's do it. Starting right at the top. What is a goiter, basically, according to your notes?
Fundamentally, it's just an enlarged thyroid gland. You see it as swelling in the neck, right? But the crucial thing, and your notes point this out, is that goiter itself isn't the disease, it's a sign.
A sign. Got it. So something else is causing the thyroid to get bigger.
Exactly. And the notes mention thyroid lumps or nodules, too.
Yes, they do.
Right, so the enlargement might be sort of diffuse, the whole gland swells up. Or you might have distinct lumps, nodules, within it. And here's a really critical point from the notes. Most nodules are benign, thankfully, but around 5%, they can be malignant, cancerous.
Wow. Okay, so investigating means ruling that out.
Precisely. Assessing that risk is a major part of the workup.
And the notes break down the types of goiter further.
Structurally, yeah, which is
Yeah.
helpful.
Yeah.
You've got diffuse goiters, just generally bigger, a single nodule in a normal-sized gland,
Right.
or multinodular goiter, lots of lumps. And the notes even specify what those nodules might be made of: cystic, colloid, hyperplastic, adenomatous, or cancerous. Knowing these types helps classify things.
Okay, so why does the thyroid enlarge? What causes it? Your notes list quite a few common things.
They do. Top of the list globally, as mentioned in your notes, is iodine deficiency. Makes sense, right? No iodine, can't make hormone, gland grows trying to compensate. Then there are the autoimmune diseases. Hashimoto's is a big one, often causing an underactive enlarged gland. In Graves' disease, usually a diffusely enlarged overactive gland.
Uh-huh. And medications, I saw that mentioned.
Yes, absolutely. Certain drugs interfere with the thyroid. Your notes specifically flag lithium and amiodarone. Good ones to remember. Also, things like pregnancy, menopause, they get a mention as less common factors.
So causes are broad. What about risk factors? Who's more likely to get one?
Well, building on the causes, iodine deficiency is a big risk factor, obviously. Family history of thyroid issues definitely ups the risk. Being female is also listed likely linked to the higher rate of autoimmune thyroid conditions in women.
Right, that makes sense.
Radiation exposure is another key one. Your notes mention radiotherapy, but also environmental exposure like Hiroshima, Chernobyl. Smoking's on the list too.
And there's that interesting bit about diet in the UK.
Yes. The milk alternative drinks potentially leading to lower iodine intake for some people. It's a good reminder that, dietary shifts can have unexpected consequences. A relevant risk factor noted there.
Fascinating. Okay, pathophysiology. The notes touch on this. How does the gland actually get bigger? What's the mechanism?
It really boils down to the specific cause, but the central theme in your notes is a disruption. A disruption in that whole thyroid hormone production and regulation system. The feedback loop gets messed up.
So if hormone levels are low, or the body needs more, the brain sends a signal.
Exactly. The pituitary gland releases more TSH, thyroid-stimulating hormone. TSH basically yells at the thyroid, work harder, get bigger, ugh. It's trying to compensate. Your notes also correctly add that direct inflammation, like in thyroiditis, or just the physical growth of nodules or tumors, also makes the gland larger.
Okay, this is where it gets tricky, right? A neck lump isn't always the thyroid. Your notes have this great section on differential diagnoses. How do we navigate that huge list?
Yeah, that section's crucial. Avoid tunnel vision. Your notes smartly divide it. Is it thyroid or is it something else nearby?
Let's tackle the thyroid possibilities first, based on your list.
Okay, so within the thyroid itself, you could have a simple goiter, enlarged but working normally, maybe with non-toxic nodules, or a toxic multinodular goiter, lumpy and overactive, or a single toxic nodule. Then specific benign things like colloid cysts, adenomas, and critically, thyroid cancer carcinoma is on that list. Plus, the inflammatory conditions, Graves, Hashimoto's, other types of thyroiditis like Dickor veins.
Phew, that's quite a list just for the thyroid. What about the non-thyroid causes of neck lumps?
This is where you broaden the net, like your notes suggest. Could be congenital things, thyroglossal cysts, branchial cysts present from birth, a really common one, enlarged lymph nodes. Could be infection, inflammation, or cancer spread like lymphoma. Salivary gland problems, tumors, stones, inflammation, those can cause neck swelling too. And then your notes have a sort of catch-all for other neck tumors, benign or malignant lipomas, fibromas, sarcomas. Thinking this broadly is key to not missing something important.
Good point. Okay, let's talk numbers. How common is goiter? Your notes seem to focus on the UK context.
Right. They mention that prevalence has dropped in the UK, mainly due to better iodine intake now. But it's still around. The notes quote about 4 to 7% of adults having thyroid lumps you can actually feel.
Palpable lumps, but ultrasound picks up more.
Oh, definitely.
Yeah.
Way more nodules are found incidentally on scans, as your notes imply. Now, the cancer connection, always a worry with a lump. Your notes put thyroid cancer at about 1% of all malignancies.
Okay. Anything specific about age?
Yes, and this is super important, highlighted well in your notes. Nodules are rare in kids, and adolescents maybe 1 to 1.5%. And this is the key takeaway, if a young person does have a nodule, the chance of it being cancerous is much, much higher than in an adult.
Wow, okay, that's a crucial red flag right there.
Absolutely remember that one.
So, clinical presentation. What does the patient notice, and what do we look for on exam?
Well, the most obvious symptom is the swelling itself, changing how the neck looks. Your notes also list neck tightness, maybe some discomfort. If it gets big enough, then you get pressure symptoms. Hoarseness, voice changes, maybe pressing on the nerves. And in really severe cases, trouble breathing or swallowing if it compresses the windpipe or esophagus.
And when we examine them, what are the key steps from your notes?
First, just look. Any visible swelling, asymmetry. Then the classic test. Watch the swelling as they swallow. Thyroid lumps usually move up. Then you feel it palpate. From behind is often best. You're checking size, shape, is it smooth or lumpy, hard or soft, tender, and always, always check for lymph nodes in the neck. Enlarged nodes could mean malignancy.
Okay, this leads perfectly into the really high-yield stuff, red flags. Your notes structure these by urgency, which is brilliant. What screams urgent action needed?
Yes, this structured approach in your notes is gold. Top emergency needing same-day referral is stridor with a thyroid mass, that high-pitched breathing sound, airway emergency.
Got it, same day. What about the 2-week rule?
Right, the urgent 2-week rule referral category. Your notes list things highly suspicious for cancer. A thyroid nodule in a child or adolescent, remember that higher risk. Unexplained hoarseness or voice changes with a goiter. A painless thyroid mass that's growing fast, like over weeks. And palpable cervical lymph nodes, suggesting spread.
Great, those are clear 2-week waits. Any other potential red flags mentioned?
Yes. Notes list others that raise suspicion. Maybe not always a 2-week wait depending on context, but definitely concerning. Family history of thyroid or related endocrine cancers, history of radiation exposure to the neck, and persistent neck pain in a thyroid area lasting weeks.
And non-urgent referrals.
Your notes cover those too. Like finding nodules when the thyroid function tests, TFTs, are abnormal, but there are no other suspicious features that often goes to endocrinology. Or sudden pain in a lump might just be bleeding into a benign cyst, usually needs checking out, but not typically a 2-week emergency. This tiered system, invaluable for revision and practice. Absolutely brilliant breakdown. So we've examined, we've assessed the urgency. How do we actually investigate? What tests do your notes say are key? First step, always, thyroid function tests, TFTs. Your notes specify measuring TSH, free T4, maybe free T3, and thyroid antibodies for autoimmune causes. This tells us if the thyroid's overactive, underactive, or normal alongside the goiter.
And imaging. Ultrasound seems key.
Definitely. Ultrasound is central, as your notes emphasize. It shows the gland structure, diffuse versus nodular, measures everything, characterizes nodules, solid, cystic, suspicious features. And it checks those neck lymph nodes again. A thyroid scan, using radioactive iodine, might be used sometimes, maybe for a suspected hot nodule.
What if we find a suspicious lump on ultrasound? How do we get a sample?
Right. If a nodule looks worrying or is big enough, the next step is usually fine needle aspiration, FNA. Your notes explain it's done with ultrasound guidance, sticking a thin needle in to get cells. Those cells go to cytology, under the microscope. That's the main way to tell benign from malignant before potentially doing surgery.
Any other specific tests mentioned for particular situations?
Yes, for a suspected medullary thyroid cancer, a specific type, your notes mention blood tests like calcitonin and CEA. And if cancer is found, CT or MRI might be needed to see how far it's spread.
Okay, incredible detail. So we've gone through the whole diagnostic process based on your notes. How do we actually manage a goiter once we know the cause?
Like your notes say, it completely depends on the cause and the symptoms. If it's iodine deficiency, you treat that. If the thyroid hormone levels are off, you manage the hyper or hypothyroidism. If it's autoimmune, you treat the underlying Graves or Hashimoto's.
Is surgery often required?
Not always, no. Your notes clarify it's usually for specific reasons. Major compressive symptoms, can't breathe or swallow properly, big cosmetic concerns for the patient, or the most common reason if it's diagnosed as cancer or highly suspicious for it.
And the outcome. What's the prognosis generally like?
Again, depends heavily on the cause. As your notes state, many simple goiters, if managed well, have a very good prognosis. Obviously, prognosis is different for thyroid cancer depending on the type and stage, but many types are very treatable.
What about complications if things aren't treated or go wrong?
The main ones listed in your notes relate to size, compression, difficulty breathing from tracheal compression, difficulty swallowing from esophageal compression, cosmetic issues, as mentioned, and that small but real risk of malignancy developing in a long-standing goiter. Plus, don't forget complications of the underlying thyroid disorder if there is one, like heart issues from untreated hyperthyroidism. Pulling it all together from these notes, what really strikes me is how a single sign neck swelling triggers this whole cascade. It forces you to think about nutrition, autoimmunity, anatomy, physiology, oncology. The absolute key takeaways from your notes have to be that structured approach. The differentials, the red flags, the investigation pathway. That's the high-yield stuff.
Totally agree. This deep dive, using your notes as our guide, really hammered home the need for that systematic thinking. Knowing the different goiter types, the specific risk factors, radiation, meds, even those milk alternatives, and especially that tiered red flag system, it just makes it so much clearer, less overwhelming. A real roadmap, like you said.
So here's something to mull over. Building on these notes, you now have a solid framework for goiter. But how can you use the other specific signs and symptoms of the underlying causes? Think about the unique features of Graves', Hashimoto's, different cancers to help you zero in on the diagnosis even earlier in the process. Connecting the goiter back to the full disease picture, that's the next level of understanding.
That's a great final thought. Really pushes you to integrate everything. Thank you so much for sharing these incredibly detailed notes for our deep dive today. It's been genuinely illuminating. We really hope this breakdown helps you nail this topic for your revision or practice. Keep exploring.